And here is a patient with zero count and develops bacteremia and pyomyositis. So we had to keep him alive, and we kept him alive with granulocyte transfusions. Neutropenic patients, severe sepsis, you give granulocytes. And we could keep him alive, and he finally took up the graft on day 14. That's the normal course, the stem cell graft. And once the graft is taken up, then you develop your endogenous blood cells. Once he developed his own leukocytes, obviously once the leukocytes are developed in the body, there was a lot of pus which was generated in the thigh and triceps muscles as soon as the leukocytes came. And the rule of the thumb is that pus anywhere in the body has to be removed. Along with the pus, we had to remove the necrotic muscle in large amount. He just had to remove it off, excise it off. Cutting the long story short, he was discharged almost after 1.5 months. And what was interesting is the thigh muscles, the triceps muscles, mainly the thigh muscles had been excised off, had regenerated back. Imagine this was happening in 2002, and that's the time when knowledge had started coming in about the plasticity of stem cells. My father was a scientist, so at home I discussed with him, and it appeared that the hematopoietic stem cells that we had given him for the bone marrow transplant had regenerated the muscles. And that was what made me interested in this field of stem cell research. We were expecting to discharge a patient without his thigh muscles, and we are discharging a patient with regeneration of the thigh muscles. And this is how the science of stem cell therapy and regenerative medicine has evolved over the years. And if you recall, this patient came around 2002, and that's the time when really, I think this pointer is not working. Okay. So it doesn't matter. So this is the time when the knowledge started coming in regarding the regenerative ability of stem cells. So what is a stem cell? This is for the general audience. These are cells which have two cardinal properties. One is self-renewal, and the second is their ability to differentiate into other cell types. So it's both. They have to maintain their pool, and they also have to get into other cell types. And you have totipotent stem cells, which is the fertilized zygote and the first two divisions, which can form the placenta and thus the whole embryo and the organism. You have the pluripotent stem cells. They can form any cell of the body but not the placenta. So they are the embryonic stem cells, and they are derived from fertilized eggs from the fertilized zygote about 5 to 7 days down the line. And then you have the multipotent stem cells, which can differentiate into limited number of cell types. And these are typically the adult stem cells. So embryonic stem cells, as I said, we don't work with totipotent because we cannot produce a whole being. But we can work with embryonic stem cells, which are pluripotent, adult stem cells, which are multipotent, and something which lies in between. Those are fetal stem cells, which are highly multipotent. They're not like embryonic, they're not like adult, but something in between. There's been, if you see, it's very nice to work with embryonic stem cells because you can make them differentiate into any cell type, ectodermal, mesodermal, endodermal. But because of the very high proliferative potential, they can form teratomas, and there are legal issues. When you take the embryo, you have to have the consent of the parents. They are normally taken from IVF clinics. Which one do you have to press? Thank you. The other side of the story are the adult stem cells, which may have a limited proliferative capability, limited differentiation capability, but do not have legal and ethical issues. And if you see, this is a breakthrough in stem cell research. Because embryonic stem cells have problems of ethics, legalities. When you give them from one donor to another donor, there may be high chances of rejection. So they say that need is the mother of invention. So people were driven into discovering what is known as induced pluripotent stem cells. Normally what you do is, you take a fertilized egg, the inner cell mass of the blastocyst is from where you get the embryonic stem cells. But here what you are doing in induced pluripotent stem cells is, you take the somatic cells of the patient and induce them into embryonic-like stem cells or pluripotent stem cells through these various reprogramming transcription factors, OCT4, SOX2, MYC, NANOG, LIN, etc. So you don't have to go through this route. You're taking autologous cells, inducing them into a state of pluripotency. And therefore there are no chances of rejection, and it eliminates the need of embryonic stem cells. And this is one area of research which got a Nobel Prize in a record period of 5 years. The research started in 2007 and 2012. John Gordon from UK and Shinya Yamanaka, you must have heard his name, he's from Japan. They were awarded the Nobel Prize in Medicine and Physiology. So if you look at stem cell therapy, the therapeutic applications, this is the medical gathering. We are always interested in the therapeutic applications. The only approved standard of care stem cell therapy is hematopoietic stem cells for hematopoietic stem cell transplantation or bone marrow transplantation for various disorders, blood cancers, aplastic anemia, genetic hematological disorders. All others have to be done within clinical trials. I really want this message to go to all faculty, to all students, that by just doing 1 case, 2 case, 3 case, and charging the patient, you cannot get away. It has to be done in an ethical manner within a clinical trial. And what are the potential uses of stem cells from top to bottom? If you start from the top, from strokes to bone and cartilage, you name a disease, myocardial infarction, blindness, deafness, multiple diabetes, multiple areas, this therapy is being researched. This is just an overview of the countries where the maximum number of clinical trials using stem cells are being conducted, and you can see it's led by USA, followed by China, and then other countries. Of course, India doesn't appear in this because we don't have that many stem cell trials which are on in the country. So the way we have moved is by using mesenchymal stem cells. And why? Mesenchymal stem cells are basically non-hematopoietic stem cells. And they have a very high proliferative potential. They are multipotent. They can differentiate into mesenchymal stem cells, but into cells of other lineages also. And what I find the most beautiful about these cells, literally beautiful, is that they have very potent immunomodulatory properties. They can silence the immune system in the body in which they are delivered. And therefore they can be given across HLA barriers. You don't need an HLA typing to use them. And they do not, the way their mechanism of action is not through transdifferentiation, it is through production of a horde of paracrine factors. And they are very easy to obtain from bone marrow, from adipose tissue, from fetal tissues. So it's a very attractive cell type for cell therapy. And the maximum number of trials in the world are using mesenchymal stem cells. So what is our approach? My approach was to look at fetal mesenchymal stem cells. So I'm not looking at embryonic because of legal ethical issues. I'm not looking at adult, but I'm looking at something in between, which is the fetal mesenchymal stem cells. And the reason being, these are the various tissues. You can get the fetal mesenchymal stem cells from aborted fetuses from the different tissues, but you can also get them from what is known as the extra embryonic tissues, like the amniotic fluid, the placenta, the Wharton's jelly, etc., which are normally just thrown off after delivery. So we began, my first PhD student in this field. We began by looking at aborted fetuses, taking out mesenchymal stem cells from the heart tissues of aborted fetuses, of course, obtaining the consent. And I remember Dr. Shrikant my PhD student, coming back to me and very excited in the morning and saying that I have found a wonder cell, a cell which, you plate at night for people who know culture work, and in the morning the flask is confluent with cells. So that was the high proliferative potential it had. So this was the story that we began with the cardiac fetal mesenchymal stem cells. And if you see here, the growth kinetics, this here, the blue is of the bone marrow and the red is the cardiac mesenchymal stem cells. So they have a very high proliferative potential. And our hypothesis was that since they've been obtained from the cardiac tissue, they will be committed immensely towards cardiac regeneration. And we actually found that. Otherwise, if you see this side, I've tried to show that they are like the bone marrow mesenchymal stem cells. They express 73, 90, 105 and do not express the hematopoietic markers. So by doing a flow cytometry or immunophenotyping, you can't differentiate. But what is nice about them is the proliferative potential and their immense predilection to develop into the cells of the cardiovascular lineage. Very beautifully, they can be induced. But that was not enough. We decided to do in vivo work. So we looked at a rat model of MI. It was a left anterior descending artery ligation rat model of myocardial infarction, where these cells were injected in one arm, saline, and in the other arm, these fetal mesenchymal cardiac cells. And what we found was a beautiful effect on the left ventricular functions. Very good regenerative effect showing in terms of the functionality of the left ventricular functions. There was an increase, significant increase in the left ventricular ejection fraction, a significant decrease in the end systolic and end diastolic volumes, and a decrease in the left ventricular myomass. And then, through Indo-Danish collaborative grant, we could get this small animal SPECT CT so that we could mimic the human system for evaluating the efficacy of these stem cells. And you won't believe it's more expensive than a human CT, because when you put rats, they're very small, so the delineation power has to be very high. And what we found was, if you see this last one here, the red, the perfusion in the arm where fetal cardiac MSCs had been given, these gaps are the perfusion gaps. The perfusion gaps had narrowed down. So there was increased angiogenesis in the infarcted area, which normally never can happen. When there's a myocardial infarction, you can just prevent it from protect the rest of the myocardium, but the dead myocardium, you really cannot do anything about. And then we sacrificed these rats also, and we found, this is, for the pathologists who are here will be familiar, this is the Mason's trichome staining and TTZ staining, which is for fibrosis and for the infarcted area. And in the fetal cardiac MSC group, there is both a decrease in the fibrosis and a reduction in the infarct size. So that was a nice story. But there was a caveat. The caveat we realized very soon is to be able to get aborted fetuses. It's not going to be, maybe in India it's possible, but in other countries it would probably be impossible to get aborted fetuses. So we decided to look at the amniotic fluid mesenchymal stem cells, because literature started coming in that they have a high differentiation potential. So first we began by comparing the amniotic fluid MSCs with bone marrow MSCs, just doing the basic work, good growth kinetics. The blue line are the amniotic fluid MSCs. But phenotypically, same markers were present, but a higher proliferative potential. And then we looked at the cardiomyogenic potency of these human amniotic fluid MSCs in comparison to the bone marrow MSCs. And we found a beautiful differentiation of the amniotic fluid MSCs into the cells of the cardiovascular lineage, as well as the expression of the cardiovascular genes in them. And then, as you go down the line, you become better and better. We noticed a paper which said that the c-KIT positive amniotic fluid stem cells, which are CD117 positive, have a cardiogenic predilection. We picked up this cue from this paper and did further work not just on whole amniotic fluid MSCs, but on the c-KIT positive subset of amniotic fluid MSCs. We sorted them out through a FACS sorter. And very interestingly, we found that in comparison to the unfractionated amniotic fluid MSCs, the c-KIT positive population had a higher cardiovascular predilection. In all, the p-value was higher when they were made to differentiate. They had a much higher differentiation potential in comparison to the whole population of amniotic fluid cells. And then we did again the in vivo studies, because before you take them to humans, you have to do preclinical animal studies. And this is what we observed. This is a healthy control. This is an MI-induced heart section. And this is an MI-induced c-KIT positive AFMSCs, so you can see very much reduction in the fibrosis. And then we went one step even further, that instead of using cells, why not use a secretome, because there is always a reservation about cells now. It's more appropriate to use the secretome. And the greatest effect we found was of the secretome. So one thing became very clear, that the c-KIT positive population, and especially its secretome, is very good in myocardial regeneration. And as I said, that this is the action of mesenchymal stem cells is not through transdifferentiation. It's through production of different paracrine factors, and other than that, the mechanism is there, then transdifferentiation. And we found that there was a reduction, when we did the section analysis, there was a reduction in the pro-apoptotic genes, pro-apoptotic proteins in the sections, in the heart sections. That is the BAX BCL2 ratio and the cleaved caspase 3 levels. The last one is, this is the secretome, and this is the one before that is the c-KIT positive population. So the most profound with c-KIT positive population, and the even more profound with the secretome. This encouraged us to go into the renal injury model, and very briefly, we are down the line, so we formed embryoid bodies. As you all know, we can form embryoid bodies from the amniotic fluid. That technology came into the world, we formed them. We could differentiate these amniotic fluid stem cells to form the embryotic bodies and express markers of all the 3 germ layers. So they're almost like embryonic stem cells. And when they expressed, because the urine is urine of the fetus is excreted into the amniotic fluid. So that's how we went into renal regeneration, and we found that these rat amniotic fluid stem cells expressed the progenitor markers, renal progenitor markers, and they could be very nicely differentiated into the renal proximal tubular-like cells. And in vivo, we gave them to a rat model of acute renal failure, which is cisplatin induced, and they produced a beautiful regeneration in this model. Here you can see the histopathology slide. And again, when we looked at the mechanism, because always when you have an observation, you want to see the mechanism of action. It was again through the production of anti-apoptotic factors. Again, the BCL2 BAX ratio, the cleaved caspase levels were decreased. So I will end here. I've given 2 examples. And being a bone marrow transplanter, I would like to again, I began with a case